my pleasure to recognize the great work of Operation Smile. It's been around for many years. Gone and worked with Operation Smile. You always come back with great stories. Operation Smile, and always come back with great stories throughout the world. Today, Jason Ham will be presenting this lecture to you. Today, Jason Ham faculty members this lecture. I hope you enjoy one presentation, faculty members, and I hope you enjoy the presentation, and I hope to see you sometime at New York University College of Nursing.
Well, good morning, everyone. While the team is working on the
Chào buổi
technical
sáng các bác sĩ ạ.
I want to
Trong khi mà
thank
chúng
you
ta đang xử lý một
for
chút cái
invitation
trục trặc
to
kỹ
allow
thuật
me
thì tôi
to
xin
be
phép
here to
được
present,
đầu tiên tôi xin được gửi lời cảm ơn
wonderful
các bạn
team Operation Smile,
vì
and to just be
sự
able to
kiện
be
ngày hôm nay
part of your community here in Vietnam.
rất là vinh dự
So
khi
thank
có mặt
you.
ở đây
It's
trong cái
an
sự kiện ngày
extreme
hôm nay.
honor and a pleasure to be here with you. To be able to share
Tôi thấy rất
some
là
of
may mắn khi mình có
my
ở hội trường này
experiences,
để
our
có thể chia
experiences
sẻ
of how
với
we
các
treat
bạn
patients back home in the United States.
những cái kinh nghiệm
My
của tôi
name is
với bệnh
Jason
nhân ở
Kim. Thank
Mỹ.
you. Thank you.
Một lần nữa xin cảm ơn.
So for this presentation, I will
Với
be
cái bài báo cáo
discussing
này thì tôi
some
sẽ thảo luận về
basic
những cái yếu
fundamental
tố rất là cơ
principles.
bản, đúng không ạ? Những cái
And
nguyên
for
tắc.
the next 2 days, I will actually be
Và trong 2 ngày
presenting
tới thì tôi
about
cũng
4
sẽ
lectures, 4 presentations for
tôi
you.
cũng
So
sẽ có
we'll start with
trình
some
bày với các
basic
bạn những cái
principles,
bài
simple
báo cáo đầy
concepts,
đủ.
and we'll be advancing to more
Từ
complex, more advanced
những cái
procedures
triết lý
as we
từ
go
đơn giản
throughout
cho
the
đến phức
2-day
tạp.
symposium. Thank you. So I am a clinician, a practicing clinician, where I
Tôi là
treat
một cái bác sĩ
patients
lâm sàng.
in a private office in New York
Hiện
City.
nay thì tôi
I'm from
cũng
New
đang
York.
thực hành
My main office
ở một
is
phòng
New
khám
York
tư
Dental
nhân.
Solutions, and I used to have a
Thì
second office
tôi
with a
cũng có
partner
cái phòng khám tôi tên là
called Long
Dental
Island Dental
Solution
Group.
ở New York.
And it wasn't
Rồi tôi cũng có một
until
cái
2017,
phòng khám khác.
after practicing as a general dentist, I decided to go back to specialty training
Và
at Rutgers School of Dental Medicine
sau một thời gian mà
to
thực hành
pursue
lâm
a
sàng
specialty in
thì tôi quyết định
periodontics.
là tôi
So now I'm
sẽ
a
tập trung vào một cái lĩnh vực,
but I practice still as a general dentist in terms
một cái lĩnh vực chuyên sâu.
of doing
Tuy
implant
nhiên thì thực tế thì tôi hiện nay thì tôi vẫn
restorative
đang
as
là
well.
một cái bác sĩ tổng quát.
I spend most of my academic teaching at NYU.
Thì hiện nay thì tôi chủ yếu là cái thời gian mà làm giảng viên của tôi là ở trường đại học NYU, đại học
Me
New
over
York.
here on the left, training and guiding
Ở đây thì cái
practicing
hình ảnh này thì
dentists
tôi
who
đang
want to
hướng
learn
dẫn
implant dentistry.
một số các bác sĩ.
Now, how many of you are placing
ghép
implants
implant.
yet?
Ở đây thì đã ai
Anybody
ghép
placing
implant rồi?
implants?
Chúng ta có thể giơ tay.
Not yet? You're in the right place then.
Nếu mà các bạn ở đây thì phần
So,
lớn các
we
bạn mà
want
chưa
to
tiếp xúc với
train
implant thì các
practicing
bạn đang ở đúng
clinicians
chỗ ở đấy.
who want to learn to place implants.
Thì
The gentlemen you see in the back, they're from
ở đây
another
thì
country
kế hoạch này
because
thì tôi dạy
NYU
cho
has
những cái bác
such
sĩ mà họ đang
diverse
muốn học về cái ghép implant.
connections throughout the world. We
Ở
have
đây thì chúng tôi
clinicians,
có
dentists coming from all over the world,
các bác
world
sĩ đến từ khắp nơi
to
trên
want
thế
to
giới
learn about implant dentistry.
tới để học về
And so this is a
implant.
2-year implant program
Đây là một
where
cái chương
practicing
trình
dentists
2 năm
will come to learn
về
implant dentistry
implant.
treating patients. So it's not just studying
Ta
and doing
không chỉ
didactics,
có,
it's actually treating live patients,
chúng ta không chỉ
doing
có học lý
everything
thuyết
from
hay là thực hành trên
diagnosis,
mô hình, mà chúng
treatment
ta
planning, to
có thực hiện
surgery,
những cái điều
all the way
chỉnh
to the final
thực
prosthetics.
hiện thực
So
sự là
this
có
is a
những cái điều
great
chỉnh trên
way
bệnh nhân.
to learn implant
Đó thì
dentistry
đó thực sự
to
là một
get
cách
the
rất là hay
full
để chúng
hands-on
ta
experience. It's
học
a
về
2-year
implant.
commitment, but certainly worthwhile. And that's how I got started
Tốn
with
2
implant
năm học,
dentistry,
tuy nhiên thì tôi
doing
nghĩ
this 2-year
thời gian đó
program.
thì nó rất là xứng đáng.
After teaching and being one of the directors for the program, our dean that you just saw, Ken Beecham, he asked me if I would take on a new program.
Hiện nay thì tôi
So I
có một
decided
cái
that
chương
we
trình
would
mới
take on
nữa.
this new 1-year comprehensive
Đó là
care
cái chương
program.
trình
It's a full month
1 năm,
rehabilitation
đúng không ạ? Về
program
cái
to teach
về cái chăm
clinicians
sóc
how
gọi là
to
toàn
treat the
diện
patient
cho
comprehensively,
về nha
how
chung
to
và
do
phục hình cho bệnh
everything
nhân.
from the interdisciplinary approach.
Thì
Because
làm
it's
thế
such
nào
a
để chúng ta
vast,
có thể
vast
thực hiện một cái điều trị liên chuyên khoa
specialty
cho bệnh nhân.
that you need to learn everything about dentistry to
phải
be able
học
to treat your
tất
patients.
cả các
So
cái
this is
lĩnh
a
vực
1-year
về nha khoa
continuum.
đó để
It's
có
a
thể thực hiện một cái điều trị
peri-pros
toàn diện.
comprehensive
Thì đây
care
là một cái
program
khóa học về
treating
cái chăm sóc
patients
toàn diện
from
về
everything
nha
from the
chu.
beginning all the way to the end. And so it's a very good program. We just finished our
Đây là một cái
second year.
chương trình rất
And
là
this
thú
is
vị và
our
tôi vừa kết
class
thúc cái năm, tức là
from
cái chương
the
trình khóa thứ
graduating
2.
class of this year, 2025. So this picture was taken about 3
đây
weeks
là cái
ago
khóa
at
mà
the
vừa mới kết
graduation
thúc,
ceremony to
năm
celebrate the
2025.
1-year completion of the peri-pros comprehensive care program.
Đây là cái
If you ever
các bác
visit
sĩ
the
tham gia
United
trường
States,
học
you're
chăm
more
sóc
than
tổng quát
welcome
về nha chu.
to come and visit NYU.
Nếu
I'll
bạn
be
có cơ
happy
hội
to show you what we do in the
học
clinic
tập cũng như
in
tham
terms
quan
of how we
NYU.
treat patients
Thì tôi hy vọng là sẽ
comprehensively
có thể có
from
cơ hội để
everything
gặp các bạn
from the
để
periodontal
các
and
bạn về
prosthetic
cái quá trình, cái
approaches.
quy trình chúng tôi thực hiện.
This is
dạy
my
học cũng như
email.
là thực hành trên
I like to give my contact just so
Đây là
that in
email của
case you
tôi.
want to
Thì nếu
reach
các bạn
out,
có
or you want to connect with me regarding some of my
nhu cầu muốn kết
cases,
nối,
or you want to
ta có
connect
thể
about
liên
your
quan
own cases,
email này.
I try
Hay
to
là
make
chúng ta có
myself
nhu cầu
available so
chúng
that
ta
we can
muốn,
really build that relationship and connection. And
hỗ
now
trợ
that
trong những cái
this is
lâm
my
sàng
first
cũng có
time
thể
in
gửi qua
Vietnam,
những
and
cái
I
email
truly
này.
appreciate and enjoying everything about Vietnam.
Cái
And
điều mà tôi
hopefully
rất là
this
thích
will
ở
not be
Việt
the
Nam.
last time I visit Vietnam. And so I hope that
Tôi
you'll
rất là thích, tôi rất là yêu
continue
Việt Nam.
to
Tôi nghĩ là đây sẽ không
continue
phải là
the
lần cuối
journey
cùng
so
tôi
that
đến
we
Việt
can
Nam.
build this
Chắc hẳn rồi.
relationship. Now I know many of you are on social media, right? You
Các
guys
bạn
are
ở đây
doing
các bạn
social
cũng
media.
dùng
How many
mạng xã
of
hội
you
đúng
on
không ạ?
Facebook?
Ở đây ai dùng Facebook ạ? Giơ
Okay,
tay
a
ạ.
few.
Tất cả.
How many of you on Instagram?
Instagram, ạ.
A few more hands. How about TikTok?
TikTok ạ.
Oh, see, this is a very good crowd because I see a lot of younger generation, right?
Đây
TikTok,
chúng ta có rất là
right?
nhiều
So
người
after I
trẻ
finish the
mà chúng ta dùng.
presentation, we may have to do a TikTok
là nhiều
together,
cái mạng xã hội.
okay? All right?
Hay là có
Because
TikTok.
this is how we share knowledge and how we share information, right? How about YouTube? Anybody do
YouTube ạ.
YouTube? Oh, very good. These are all great social media
Đây đều
platforms.
là những cái nền
And
tảng
something
mạng
that
xã
we've
hội
been
rất là
more
tuyệt
active
vời.
with because when I first started, I didn't believe social media.
Hồi trước
But now,
khi mà mới tiếp
after
xúc thì tôi
being
không tin vào cái mạng xã hội này.
involved
Nhưng mà
and more
dần
active
dần
with social media, we have
khi mà tôi
Facebook,
tham gia những
we
cái
have
mạng xã hội này,
Instagram,
chúng tôi có Facebook,
we
có
do
Instagram,
TikTok
có
videos,
TikTok,
and we do YouTube.
rồi YouTube.
And it's actually shown to be very, very effective and very
Thế thì nó là một
positive in
những
terms of
cái
how we can
công cụ
share
rất là hữu hiệu,
information, not
đúng
just
không ạ?
with
Để
our
chúng ta có thể chia
colleagues,
sẻ kiến
but
thức
with the general patient population.
không chỉ với
So with
bệnh nhân mà còn với
YouTube,
cả
where I
đồng nghiệp
practice
của
in
mình.
New York, we have a very highly densely population of Asian patients.
Với
A
cái
lot
kênh
of
TikTok này
Korean,
chúng tôi có
Chinese,
cái cộng
Vietnamese,
đồng
Filipinos,
những người
Indians,
theo dõi
many
rất
patients
lớn đến
from
từ
all
châu Á.
over Asia. And so because of where I practice, there's a lot of Chinese patients. We
Và
decided to
thế
build a
tôi
YouTube
cũng
channel
điều trị rất là
that's
nhiều đúng không ạ?
focused
Những cái
towards
bệnh
the
nhân mà
Chinese
có
community.
gốc Trung Hoa.
And so
gốc
we
Trung Quốc.
would
Sau đó thì
make
tôi
these
đây
little
là một cái
simple
kênh
videos like
rất là hiệu
what
quả
is an implant? What's
để có
the
thể giới
difference
thiệu cho bệnh nhân
between
những cái kiến
a
thức nha khoa
ZimV
như là ví
implant
dụ
or
như là
another
implant nha
company
khoa là gì,
implant?
hay là giới thiệu những
What's
công ty
bone
implant như
grafting?
ZimV,
What's all on
hay là
X? Right? So all those little ideas, we
vật
make
liệu
a
ghép
little
xương là
video
gì,
and very
vân vân.
simply
hay là
describe
all this là gì.
the content.
Đó
And
thì
so we make
chúng
these
ta có rất nhiều
videos
cái nội dung để
and
có
we'll
thể
translate
chuyển
it
nó thành
into
cái nội dung trên mạng xã hội.
Chinese. And we were up to 249,000 subscribers. So when I first saw this, I didn't
Và
believe
nay thì
it
chúng
because
tôi cũng có
how
rất
is
là
that
nhiều những người
possible?
theo dõi, thậm chí là trên
249,000
các cái nền
people
tảng khác nhau.
are watching my YouTube. And then after less than 1 year,
Và
we
chỉ
were up
trong
to
vòng ít hơn 1 năm
333,000.
tôi đã
So
có hơn
it's
300.000
crazy,
người theo dõi.
right? But I started to really believe it because
Và
my
đây tôi thật sự
family,
tôi
my
thấy
children, my staff were saying, You need to use these
tôi nghĩ là
platforms
những cái nền
because
tảng này
it really
thì rất
spreads globally.
là hữu hiệu để
And so
chúng ta có
now,
thể
I'm a firm believer in
truyền tải
social
những cái thông tin
media
trên toàn thế giới.
and understand that it can bring a lot of value, a lot of good
Nó có thể đem
information.
lại rất là nhiều
Yes,
những cái
there's
thông tin
bad
giá trị.
information, but we gotta have to filter it and use the good information.
Tuy
So
nhiên thì chúng ta cũng
YouTube,
sẽ cần phải chọn
Instagram,
lọc
Facebook,
những cái thông tin
it
tốt
really is a powerful
ở trên mạng xã hội
platform.
này.
And so
Nếu chúng ta
thank
chọn lọc được thì
you
nó
for
sẽ là
allowing me
những cái
to
nguồn thông
use
tin rất là
that.
tốt.
And now that I said that, we have to do one thing for me and my office.
Và cuối cùng thì chúng ta sẽ phải làm một cái điều,
We're going
một cái
to
thủ
do
tục đúng không ạ?
a little video.
Đó là chúng ta sẽ phải
So,
quay video
hello Vietnam!
để thầy đăng lên mạng xã hội.
Yes! Thank you, Operation Smile. Thank you, Vietnam National University. It's going to be a great week. It's such an honor and pleasure to be here.
Chúng ta
Let's
sẽ
do
có thể vỗ
this.
tay, vẫy tay,
Yay!
vẫy tay ạ, vẫy tay ạ.
Thank you, thank you. So, with that, we'll go to the presentation.
Chúng ta hãy cùng vào
So, I want you to look at these
phần chính
pictures.
của
These
bài
are
này.
not my cases.
Các bạn hãy nhìn vào
These
cái
are
hình ảnh
cases
này.
that I took
Đây
from
không
the
phải là cái lâm
internet.
sàng của tôi. Đây là
Right?
những cái lâm
Look
sàng
at
tôi
these
sưu tầm
implant
trên internet.
cases.
Các bạn hãy nhìn
Look
những
at
cái
this
hình ảnh
implant
này.
case. How about this case?
Cái
Is
này
it
thì sao?
good?
Nó
Is
có
it
tốt không ạ?
bad?
Nó tốt hay là nó
Maybe,
tệ?
maybe not.
Có thể.
How
Có
about
thể
that
tốt, có thể
implant?
tệ. Rồi
Right?
implant
If
này
you
thì
look at
sao?
that implant, they say, ooh, that's very, very deep.
Chúng ta nhìn vào cái
How
implant
are
này
you
chúng ta thấy
gonna
là
build
nó
a
đặt quá là
crown
sâu.
over that
Làm
implant?
thế nào để chúng ta có
Can
thể
you
phục
build
hình
a
được cái
crown?
implant này?
Right? So very difficult.
Rất là khó.
How about this
Hay là
implant
trường hợp này
case?
thì sao?
This actually happens very often, right?
Thực tế là đây là
Do
một
you
cái tình
know
huống rất
why
là
this
dễ chúng ta
happened?
gặp trên lâm sàng. Tại sao?
There's a couple reasons why
Có một
maybe
số
it
những cái
happened.
lý do
And so
mà
when
nó
I
sẽ-
see these
nó rất là
types of
dễ
cases,
xảy ra.
I want to ask, like, why did this happen?
Tuy nhiên thì có những cái
How
tình
did
huống
this happen?
tôi không hiểu sao lại nó có thể xảy ra
Is
trên lâm
this
sàng được.
acceptable?
Nó không thể chấp
It's
nhận được.
certainly not acceptable. No matter where you practice in the
Dù chúng ta là
world,
đang thực hành ở đâu,
doing implant surgery like
nếu
this
chúng ta
cannot be
thấy những cái
acceptable.
implant nó để cái vị trí
Because
cái
we
trục
know it's not
implant
gonna
như thế này,
work.
thì đó là cái điều
It's
kiện
gonna
chấp nhận
fail.
được. Vì chúng ta biết chắc chắn là
If
nó
you look
sẽ
at
thất
this
bại.
case,
Nếu chúng ta nhìn vào cái hình ảnh bên
probably
trái
the clinician who placed
Đôi
the
khi-
implant probably did a flapless.
thì cái
We saw a
người
great
bác sĩ mà
presentation
thực hiện
just
cái ca
before
lâm
earlier
sàng
with
này,
Dr. Town showing
bác sĩ
you
đấy không có
the
lần vàng.
value and how guided surgery can play an important
Đó
role
là
in
cái lúc
being
mà chúng ta
more
nhận ra cái giá
predictable,
trị
in
của
being
những cái
accurate,
phẫu thuật không
in
lần
being
vàng mà sử
successful.
dụng những cái công cụ có hướng
This
dẫn
is
như
certainly
là
going
mảng
to
phẫu
be
thuật.
predictable to fail.
Tuy nhiên thì nếu mà
It's
chúng
going to
ta
fail
gặp
because
những cái
there's no
biến chứng
bone
như thế
on
này
that implant.
thì đó là một cái implant
So
có
this
tiên lượng
probably
được, có thể
happened
tiên lượng được
because
nhưng mà chúng
they
ta là có thể
probably
tiên
did
lượng
it
được
as
là nó
a
sẽ thất bại.
flapless approach,
Do đó
not
thì khi
knowing
mà
if
chúng
there
ta
was or wasn't any bone.
thực hiện những cái
So
phẫu
we
thuật
want
không
to
lần vàng
avoid
thì
these
một
types
cái
of
nguy cơ đó là
cases.
chúng ta không biết được là
And we
implant
can
nó có nằm
certainly
thực sự nằm trong
avoid
xương hay
them
không.
if we do the
Để chúng ta
proper
có thể
planning.
tránh
And
được
so
những cái nguy
understand
cơ
that
này
we want
thì chúng ta sẽ cần phải có một cái
simplicity,
kế hoạch phù
right?
hợp.
We heard that already this morning. But we also want predictability.
Thì chúng ta không chỉ
We want to
muốn là
know
đơn
that
giản
it's
hóa
going to
cái
be
quy trình mà
predictable
chúng
to
ta cần phải muốn cái
see
quy trình đó nó
that it's
trở
going
nên
to
dễ dàng
work.
tiên lượng hơn.
No matter which patient,
Dù
no
là
matter who you treat it
cái
on,
bệnh nhân đó
that
là
it's going to be
ai,
successful.
người dễ tính hay khó tính.
And when we look at those cases, all these cases
chúng ta
that I
nhìn những
pulled
cái ca
from
lâm
the
sàng này,
internet,
những cái ca lâm sàng mà
these
tôi tìm
are
ở trên
all
internet,
very, very similar, right?
những cái ca lâm sàng này
What's the
đều có một
common
cái điểm
issue
rất là
with all of
chung.
these cases?
Có cái vấn đề gì với tất cả
What's the
những ca
main
lâm sàng này?
problem with these cases? Right?
Cái yếu tố- cái
Very
nguyên nhân chính
predictable. Predictable to fail,
đó là những cái
because
ca
there
lâm
was
sàng rất là dễ
poor
dự đoán,
treatment
dễ dự
planning.
đoán là nó có thể thất bại, nó sẽ thất
poor
bại trong tương lai.
treatment planning, or
Vì là nó
there
không
was
được
no treatment planning.
không có một cái kế
Meaning,
hoạch điều trị.
patient probably came to
Phù
your
hợp.
office and the clinician just saw a
thất bại
space
từ cái
and
bước
said,
chúng ta lập kế hoạch
okay,
điều trị.
let's put an implant there.
Đơn thuần là những
So
ca lâm sàng
maybe
này tôi đoán
sometimes it can
đó
work,
là
but
bệnh nhân
maybe
đến với nhu
sometimes
cầu
it
là
won't
cấy
work.
implant thì bác sĩ
For
yêu cầu
those
cấy
reasons
implant
that
thôi.
we just saw,
Đã thiếu cái kế hoạch
right?
điều trị
Because there's no planning
vì
involved.
chúng ta không có một cái kế hoạch phù hợp.
And so we need to understand, how do we get to where I want to go?
Chúng ta
How do I
cần phải
get
mong
to where I
muốn rằng
want
là
to go?
chúng ta cần phải biết là chúng ta đến đâu,
Especially
và
today,
chúng ta đi như thế nào.
2025, with technology, right, with the advancement of
Ngày nay thì với
information,
những cái công nghệ của
with
chúng
the
ta,
internet,
với cái
it's
sự phát
much,
triển
much
của
easier,
internet thì chúng ta
much
rất là
more
dễ dàng.
predictable.
Đó.
Like here in Vietnam, for
Ví dụ
me,
như ở Việt Nam,
I want to go
với
to
tôi,
Old Quarter. How do
ví
I
dụ như
get to
tôi
Old
muốn
Quarter?
đến
What do I do?
phố
I
cổ
pull
đi,
out the phone,
tôi chỉ
I
cần
put in
gõ
the
là
GPS,
phố cổ, đúng
right?
không ạ? Ở
And then I
trên
put
Google
in
Maps
what?
thì tôi
I put in the final destination of where I
tôi chỉ
want to
cần
go.
biết là cái điểm đến của mình
Right?
ở đâu.
And so if you
Sau đó
come to
thì
the
phần
United
mềm sẽ
States,
tính
you're
toán
going
cho
to do
chúng
the
ta
same
di
thing.
chuyển như thế nào.
I want to go to NYU. How are you going to get to NYU?
Ví dụ
You're
như
going
là
to
các
take
bạn
your
muốn đến
GPS,
NYU, đúng không ạ?
your
Các bạn chỉ
Google
cần
Maps, and you're
mở
going to put in
Google,
the address, the
bật
final
GPS
address of
và
where you
chúng ta
want to
gõ
go.
NYU.
So you need
Đại
to
học
put in
New
your
York
final
là thế.
destination.
Chúng ta sẽ
Same thing
có
with
cái
implant
hướng dẫn
dentistry,
tới
right?
cái
We
địa
need to
điểm đó.
understand what's the final goal
Do đó thì
for
điều đầu
that
tiên
patient.
chúng ta cần phải
What's the final
xác định
result,
đó là cái
final prosthesis
mục
for
tiêu
that
cuối cùng
case.
cho cái ca lâm sàng đó
And
là
so
gì.
we want to be predictable,
Chúng
we
ta
want
muốn
to be
là cái điều
successful,
trị ra thật sự
but we have to
là dễ thương
understand
lượng
there's
và
going
thành
to
công.
be road blockages, there's going to be disruptions, but we want to
Chúng ta có
minimize
thể
those
đôi khi trong cái
complications.
con đường đó nó
And
sẽ
so
có
we
những cái khó
want to
khăn,
make
nhưng
sure
mà
that
nếu
we
chúng ta
can
xác
have
định được
full
mục tiêu
control, and especially
thì chúng ta sẽ
today
thấy là
with
dễ
digital
dàng đi hơn rất là
technology,
nhiều.
we have the tools, the information,
Ngày nay
and
thì
the
với công nghệ
capability
chúng ta
to
có
be
rất là
able
nhiều
to
những cái
get
công
to
cụ khác nhau
the final
đó
destination
để chúng ta có thể
predictably
tìm được
and
cái
successfully.
cách chúng ta đi tới cái
And so
điểm,
we have
cái
to
mục tiêu cuối
understand
cùng.
this quote. It says, "He who fails to
Và
plan
một cái câu nói
is
rất là nổi
planning
tiếng
to fail."
của Winston
And so that means
đó là
a
những người
great
mà thất
thing,
bại trong việc lập kế
because
hoạch
if
thì
you
họ
don't
đang lập kế hoạch cho việc thất bại.
plan properly,
Bởi vì nếu chúng ta
it's
không
not
có
going
lập
to
kế hoạch
work.
một cách phù hợp,
Or
những
you
cái điều
may
chỉnh
run
ra nó
into
sẽ không có hiệu quả,
complications.
hoặc là
And
chúng
how
ta
are
sẽ
you
đối
going to
mặt với
manage
biến
those
chứng.
complications? So we want to be able to minimize those
Chúng ta
problems.
muốn
I'm not saying you're not going to have
chúng ta muốn giảm thiểu
complications,
những
because
cái
we
nguy
will
cơ đó.
all have complications. I've
Chúng ta
had
biết
my
rằng là
share, and
cái
you'll see some of the
biến chứng là những cái
complications
điều tất yếu
throughout
xảy
these
ra,
next
đúng
2
không? Chúng ta
days
luôn luôn
of
ai
my
cũng gặp biến chứng,
cases.
nhưng mà chúng ta muốn
That
giảm
you
thiểu
want to
cái
plan
nguy
your
cơ đó
cases properly.
thì chúng ta
You want
cần
to plan
phải
your
lập
cases
kế hoạch cho cái ca đó
predictably.
một cách phù hợp.
Okay? So understanding that we need to have some type of a plan. We need to have some type of guidance to help us,
Do đó thì khi mà
allow
chúng ta
us to
đã có
plan our
chúng ta
cases
cần có nhu cầu
to
cần phải có
get
một
to
kế
that
hoạch.
final
Kế
result
hoạch
that's
đó nó
going
sẽ
to
đóng
be
vai trò là cái
predictable,
hướng dẫn
that's
cho
going
chúng
to
ta
last, and that's
cách
going
mà
to
chúng ta
be
sẽ thực hiện cái
successful.
mục tiêu đó, làm thế nào để chúng ta đạt được
And so we
thành
have to
công.
understand we have to begin with the
Vậy thì
final
cái cách ở đây đó
restoration.
là chúng ta luôn luôn phải bắt đầu
Begin
với
with the end in
cái sự
mind.
kết thúc trong
And
tâm
you're
trí.
going to hear that the next few
Chúng ta
days
phải
from
bắt
not
đầu
just
với cái
myself,
mục đích sau cùng.
but even from my colleagues as well. We need to follow
Chúng ta
crown
cần phải
down
theo một
protocol.
cái quy trình đó là
Right, what does that mean,
từ
crown
trên
down
xuống, từ
protocol?
phục hình xuống,
It
từ mão răng
means,
đi xuống.
what's the final restoration?
Chúng ta luôn luôn phải xác định là cái
Is
phục
it
hình sau
going to
cùng
be
chúng ta sẽ là
a
gì.
cement retained crown?
Liệu nó là một
Or
cái
is
phục
it
hình
going to be a
bắt vít
screw retained crown?
hay là một cái phục hình
Is
gắn
it
xi
going to
măng?
be a zirconia crown?
Nó sẽ là một cái
Or a
mão răng
PFM?
zirconia hay là một cái mão răng
Those are the
kim loại.
decisions you have to make,
Chúng ta phải đưa ra những cái quyết
right?
định. Điều
So, you have to follow the
chúng ta
crown
luôn
down
luôn phải bắt đầu
protocol.
từ cái mão răng đi xuống.
So when we look at this is my
Chúng ta
case.
hãy nhìn cái ca lâm sàng này. Đây là ca
How
lâm
would
sàng
you
của tôi.
critique this? What would
Các
you
bạn sẽ đánh
say
giá ca lâm sàng này như thế nào?
about the implant placement?
Về vị trí implant
It's probably a little too buckled.
có thể là hơi
Okay,
lệch ngoài một tí.
we can
đúng không
agree.
ạ? Có
It's
thể
okay, you
chúng
can
ta đồng
critique
ý như
me.
vậy, đúng không ạ? Nhìn ra
Okay?
chúng ta thấy có vẻ
I'm
là hơi
okay
lệch
to
ngoài.
share my failures and my mistakes because that helps me to learn
Tôi rất là
how
thích
to
chia sẻ
avoid these
những cái
problems in the
thất bại
future.
của mình. Bởi
Here's
vì đó
another
là
one
cách
of
mà
my
để tôi
cases.
làm tốt hơn trong tương lai. Hay là
What
ca
would
lâm
you
sàng
say
này
about
thì
that
sao?
implant placement?
Mọi người sẽ đều sẽ
Look
chê
at
về
where it
cái
is.
implant, đúng không ạ?
It's very light, it's green. Yeah. That placement is probably too facial.
Cái implant này thì nó bị lệch
Right.
ngoài quá nhiều.
It still worked, it was still successful,
Nó sẽ vẫn tồn
but I
tại trên
probably
miệng,
could have improved it
vẫn có thể phục hình. Tuy
by
nhiên
doing what? By
chúng ta có thể
planning
cải
better.
thiện nó, đúng không ạ? Có thể
Right?
cải
You
thiện
saw
cái điều
Dr.
chỉnh này
Town's presentation.
bằng cách là chúng
How
ta
do
lập
you
kế
do the
hoạch tốt
surgical
hơn.
placement, using surgical guides? It's
Chúng ta có
all
thể
about the planning.
Giống
And
như
if you
trong
could
cái bài
plan
của
your
bác sĩ
cases, you
Thao,
can
đúng không ạ?
avoid
Just Thao thì chúng ta nói
these types
rằng
of
là cái
final
việc chúng ta
results.
sử dụng cái màng
It
dẫn phẫu thuật
still
chính là một
worked,
cách để chúng ta
but it
đặt
could have been
implant tốt hơn.
better.
Bằng cái
Because
cách mà
for
chúng ta
this
lập kế hoạch
case,
tốt hơn.
today you probably cannot restore this as a screw retained.
Chúng ta biết
Remember,
rằng là
he
với những
spoke
cái ca
about
lâm
screw
sàng như ở
retained
hình bên tay
crown,
phải,
especially in the anterior maxilla.
chúng ta không thể nào chúng ta làm một cái phổi
This
bắt
one,
vít được, đúng
you
không
probably cannot restore as a screw retained.
ạ? Chúng ta bắt buộc
So
chúng
the
ta
only
phải
choice you
làm một cái
have
phổi
is
gắn
a
xi măng.
cement retained. That's because I did not
Đó
plan
bởi
this
vì rằng
with the final
cái
goal,
nguyên nhân
with the final
cái kết quả
restoration
này
in
xảy ra
mind.
bởi vì tôi
I
không
just
có
wanted to get the implant
tôi không có
in
lập kế hoạch
and
một
then
cách
figure
đầy
out
đủ
how
mà
I'm
từ
going to
của
do the
mình.
crown
Tôi không có
after.
suy nghĩ rằng là cái mão răng sau
When I
này nó
do
sẽ
this,
như thế nào.
you know you cannot do this as a screw retained crown.
Khi chúng ta nhìn thấy một cái implant, vị trí implant như thế này, chúng ta biết là
So
chúng ta
this was not
không có
following
thể
the
nào
crown
chúng ta
down
làm một cái
protocol.
phổi bắt vít được. Bởi vì chúng ta
Here's
không có
another
đủ cái
case.
quy trình.
This one, the bone dictated placement of the implant, meaning
Quy trình
we
là-
went and did an uncovery for this stage, for this case. This was an implant I placed. I'm doing my uncovery, the exposure.
Tôi có đặt một cái implant.
Look at where the
Thế là,
implant is.
Sau đó thì tôi ở cái
Right?
bộc lộ
How would you
lên,
critique
tôi
it?
có,
It's probably too
làm một cái
lingual.
tôi tăng cái lợi
Right?
sừng hóa ở mặt
It
ngoài.
integrated, it healed,
Thì ta thấy là cái vị
but
trí
the
implant nó bị
placement
lệch
is
vào-
not
lệch vào trong
ideal.
quá nhiều.
It's not in the
Nó
perfect
vẫn có thể
position.
phục hồi, nó cũng có thể làm
With
cái phục hồi
today's
trên được,
technology,
nhưng mà
we
nó-
should have
nó không có
implants
số ít.
placed in the perfect, ideal
Ngày
position.
nay thì cái tiêu chuẩn implant là nó phải được đặt ở
Look at where the implant is. I have great tissue, right? Because now I'm a periodontist, I look at the tissue a lot more, right? But look, placement is too lingual. Ideally, the implant, if you evaluate this and put a prosthesis on there, look at the implant position relative to where the final crown is going to be. Not the ideal position, but it can still work. But look, it wasn't thought through following the crown down protocol. Ideally, that's where the implant should have been, right? So I learned from my mistakes. I learned from my previous cases, and I see these cases and I look at them and say, I could have done this better. I could have planned it better. And so knowing that that was probably the ideal position, this was not prosthetically driven. Right? Some people say it was more surgically driven, or some people would say it was more financially driven. Right? You just want to make a few dollars on the case. That's what happens. Okay? So this was not following prosthetically driven implant dentistry. So this probably needed some bone graft, right? The reason I placed the implant in the lingual position was because that's where the bone was. 20 years ago, if you had a case like this, and you sent it to, say, the surgeon, or if you're doing these cases yourself, the reason and the excuse you give is that's where the bone was. So if that's where the bone was, that's where the implant was. But today, 2025, if there's no bone, what do we want to do? We want to do bone graft to allow us to place our implants in a more ideal prosthetic position. Okay? Right? So we could have probably maybe done this better if we did this as a guided surgery. Placing the implant, because then we can plan our implants in the ideal, proper position. And so understanding that's our cases that we want to be able to be predictably and successful. And so when we look at implant dentistry, the ultimate goal of dentistry is what? To be able to take our patients who are missing teeth or who are about to lose their teeth. We want to be able to understand that they're going to lose function now because of losing teeth. And as a result, they're going to require some type of a prosthesis. Whether it's a fixed prosthesis or a removable prosthesis, it is going to be our goal to be able to restore them with function and aesthetics, to allow them to have a better quality of life. That's essentially what we want for all of our patients, right? To improve their quality of life, to be able to chew better, to be able to digest their food more efficiently, right? Because everything is all tied and connected in the body. And it all starts with, are the patients able to chew properly? Can they function and properly digest their foods, right? So that is our goal, improvement of quality of life. Now, when you look at these cases, we have many, many different options of how we can restore patients. And it is your goal as the clinician to be able to come to a decision with the patient in terms of what's going to be the best final result for that patient. What's going to be the best final long-term result for that patient. If a patient's edentulous, right, can you restore them with an overdenture case? Or maybe the patient doesn't like dentures, right? They cannot tolerate dentures. Then what's the next option? Well, maybe we can convert them to something like a hybrid. Place a few more implants and then have something a little bit more stable. But it all depends on the patient's health, what's the patient's expectations, and how much can the patient afford, right? Can they afford something like this, a traditional full arch of implants? If the patients can afford it, maybe that's the best scenario. But if the patients can't afford it, then maybe at least starting with something very simple with 2 implants and give them an overdenture. That's going to change their lives because they have something more stable, more retentive, they can chew better, they have more confidence. And if you can do this type of a case for a patient, what happens is the patients realize the value of what implants can do for them. They realize that, oh, I can place implants and have something more stable and retentive. Well, maybe I can only do 2 this year. Maybe I'll work a little bit more, save some money. Then maybe I can change that to something more fixed, more stable, and do this. Right? And so those are the things that you want the patients to start thinking about. Right? Mr. Lee, we can give you 2 implants, give you something more comfortable, more stable, and then think about maybe converting that to something a little bit more attentive where you don't have to take the dentures out? Would you like that? And patients, they start thinking about that. And they understand and realize the value of what implants can do. It really does change their lives. Now, many of you are very, very young, I can see. Think about your patients coming in. Think about yourself if you were missing teeth, right? Always put yourself in the position. If I lost all my teeth, what would I prefer? What do I want in my mouth? I want something more stable, more fixed, something with implants that I don't have to take out at night. And so that's going to be that ultimate goal. And so those are the decisions that you want to make with your patient in terms of understanding what's the best final result for that patient, for that case. Okay? So when we look at the procedures and the steps that we do, this is what we do every day. We talk about diagnosis, we talk about treatment planning, right? We talk about implant placement, we talk about, right, what's the final prosthesis. Many times we talk about the prosthetic procedure at the end. Many times we talk about the final crown at the end. You can't do it that way. You can't do it that way. When the patient comes in at the top, you have to think about this on day one. You have to think about, how am I going to restore that patient from the very first day the patient comes in and sits in your chair? So we have to actually think backwards, if you think about it. Think backwards, meaning, what's the final goal? What's the final prosthesis? This is what Mrs. Jones wants. This is what Mr. Lee wants. He wants crowns, single units, screw retained crowns. Then we have to figure out what's the plan in terms of how do we get to here from there. So we have to think about this, yes, but thinking about this from the first day. And then understanding, okay, these are the types of crowns I want. Then where am I going to position those implants, right? How am I going to treat that surgical case? Many, many things to think about. And so understanding your experience, your expertise, and what you think is going to be the best way to get to that final goal. So it all begins, yes, with the diagnosis and treatment planning, but you have to tie in the final prosthetic result. What's the final goal? How am I going to get to that final end result? And so when we look at the aging population today, especially in the United States, people are living longer. The average life expectancy keeps getting older and older. That's because people are more healthier today. People are exercising, dieting better, they're eating better foods, the quality of foods is getting better. So 65 in the United States is not considered retirement anymore. If people are retiring at 65 and they're living longer, and you're doing something like implant dentistry, that has to last a long, long time. 20 years, 30 years, maybe even longer, right? So we have to understand that implant dentistry should last decades, 20 plus years. And we have the science, we have the studies, we have the results to prove that it can last 20 plus years. I have cases in my own practice that have been lasting for 20 plus years. Okay? So who are the ones that are placing implants? Today, or back in the old days, it used to be just the specialists, just the surgeons, just the periodontists. Only the specialists were placing implants. Today, we have everyone placing implants. Right? How many of you, is there specialties in Vietnam? Yeah. So today, all the specialists are placing implants, as well as the general practitioners, the general dentists. And we see that all over the world, where all disciplines of dentistry are placing implants. The surgeons, the periodontists, the prosthodontists, the endodontists are placing implants. But more is the general practitioners, the general dentists that are placing more and more implants. They did a study in 2002, this is in the United States, where they found that only 5% of the general dentists were placing implants. That was 2002, I'm sorry. In 2005, 3 years after, they did the same study. They found that percentage increased to about 15 to 20% of general practitioners placing implants. Today, 20 years later, 2025, what do you think that number is? That number is much higher today. Right? The universities are teaching implants in the schools. Right? All the schools, the companies are teaching general dentists to place implants. So that percentage is much higher today. So implant dentistry Although it's not yet considered a specialty in the United States, there are more and more practitioners, more and more dentists today that are placing implants. I've had endodontists placing implants. I've heard of orthodontists placing implants. Right? Why would orthodontists place implants? What kind of implants are they placing? They're placing these mini implants called TADs, temporary anchorage devices, to help move teeth. Right? So orthodontists are placing implants. Anybody studying orthodontics here? No orthodontists? Oh, okay. Some of you are doing orthodontics. Right? So many different disciplines in dentistry are placing implants. I haven't yet found a pediatric dentist placing implants. Right? So not yet. Right? But maybe one day they will. So who knows? But it's changing. And change is good. Because change helps us to think. It makes us think in terms of what to do better. How do we make it better? And as a general dentist, that's what we want to do. Now, if you think about the history, so we're doing a little bit of basic information, basic implant dentistry, but we also have to understand the history, right? Because in the past, the types of implants are not the implants that we place today. Before, these are the subperiosteals, the blades, if you've heard of, ramus frames, right? These are the types of implants that were not intraosseous, right? But these are extraosseous implants that were placed. Today, it's some type of a root form implant, right, that we're placing implants. Whether it's an internal hex, an external hex, right? Some type of a two-piece or one-piece implant. So many different types of implants that are placed today. But majority of implants today is some type of a screw fixture with an internal connection that we're placing on patients. We've seen that those are the best results, that gives us the best outcomes with long-term success. Right? So mini implants are being used today, right, for certain reasons, and we'll explain those later. Right? But understand, why do we want to place implants? Why do we place implants? Because if you think about placing a 3-unit bridge versus single implant tooth, which is better? Which do you recommend to the patients? So we think in the single tooth implant is going to be better for the patient. With a 3-unit bridge, think about having to prepare those teeth to do a 3-unit bridge. There's advantages and disadvantages, right? But you have to give the patient those options and then come to the best result. So explain to the patient what's the best clinical outcome, what are the advantages, what are the disadvantages of placing an implant versus a 3-unit bridge. Right? What about having a removable appliance or something more fixed? Which does the patient prefer? Obviously, most patients would prefer something more fixed. Implant supported, implant retained, something a little bit more stable. Okay? And today in the United States, the standard of care is we have to explain and introduce implant dentistry to patients. Explain some of the options that include implants. Right? And if we don't present that as an option, that's going to be neglect and almost considered malpractice for us in the United States. So we have to give the option of implants as an option, even though they may not be able to do it or afford it, but knowing that it is an option. So implant dentistry. And so today, because of social media, internet, more people are educated about dental implants. There's so much information on the internet about dental implants. Sometimes they come in with more, they think they're the dentist. They come in and they tell me what implants to place sometimes, right? So patients have a wealth of information because of internet today, because of technology. So advantages of implants is we know they work. There's a proven history, a proven track record of dental implants. They're successful. We don't get caries. We don't get endodontic issues. There's no sensitivity problems, right? There's no sensitivity to cold or hot, right? Because there's no nerves in implants. So we know they work. And then just mentally, psychologically, patients, they want implants, right? Because of all the information available. They know it's better. It also helps build your practice with implants. And if I wasn't doing implants today, I wouldn't be here presenting to you today. Because implant dentistry really changed the way we practice it in our practice. Because we think it's the best option. And so we present it as the best option to the patients. And so it really does build your practice, and financially it does build take you to another level. Okay? So,
Rồi cuối cùng là
who are the patients that
cái
can
tác dụng
receive
phụ hơn
implants?
mà implant thì
Right?
nó sẽ đem lại cái
We get
cao hơn.
all different types of patients coming into our
Đâu là
office.
những cái bệnh nhân mà cần
And so
có
there are
thể
patients
được
that probably are not good candidates, but the question I ask is, who are the patients that cannot receive implants?
Thực tế thì cái câu
Because I
câu
consider
hỏi tôi
every
nghĩ là
person that
cần
comes
phải hỏi
in
nhiều hơn đó
as
là
a potential
đâu là
candidate for
những người
implants.
mà không nên thực hiện,
What types of
không nên-
patients do you
không
think
nên,
cannot place,
à,
you cannot
đặt
place
implant?
implants? Who are not good candidates?
Vậy thì đâu sẽ là những
Maybe
bệnh nhân mà
uncontrolled
không
diabetes,
nên được đặt implant?
some type of medical condition,
Có thể là những
right?
cái bệnh nhân mà
They
không
may
có
not be
tiểu
good
đường,
candidates.
có tiểu đường nhưng mà không kiểm
Maybe
soát, nên là
patients
bệnh nhân
taking
có những
these
cái vấn đề về
osteoporosis
cẩn thận,
medications,
bệnh nhân
they're
có
not good
những
candidates
cái,
for medicine, for implants.
hay bệnh
What
nhân
about
bị loãng xương,
smokers?
hay là
That's
bệnh
been
nhân,
debated.
hút
Patients who
thuốc,
smoke,
hút thuốc thì nó vẫn là một
right?
cái
So that's been
đang cần
controversial.
phải trải.
But I always see every person, every patient that comes in as a potential candidate for implant dentistry.
Tôi luôn luôn nhìn nhận
So it
những
really
bệnh
takes
nhân
a lot to
đến
be
với
able
phòng
to
khám
say,
mình là
no,
những
you
cái,
cannot do implant dentistry.
ứng cử viên tiềm
Maybe
năng
certain
để
medications
được
the
cấy
patients are
implant,
taking
nguyên nhân
will
thực tế.
prohibit you from placing implants,
Cái câu
but
hỏi
those
ta
are
nên đặt
things
là
that you need to understand,
có
you
những cái
need
trường
to
hợp là chúng ta cần
gain,
phải chống chỉ định
you need to
không
gather all that information so you can make the proper diagnosis and planning
Đó,
for the
chúng ta phải khai
patient.
thác bệnh nhân, đúng không ạ?
Right? So we have to begin with the end in mind. Right? I said that earlier. What's the final goal, the final prosthesis? Implant dentistry has to be prosthetically driven. It wasn't like that in the past, 20 years ago. It was more surgically driven. Today, it has to be prosthetically driven, and we have the ability, we have the tools to allow us to be prosthetically driven. Even if you're just a surgeon or just a periodontist that's doing just the surgery, you have to do that with a prosthetic mindset. Because you have to send the case back to your referring doctor, or if you're not doing the restorative, understanding that the final prosthesis has to be prosthetically driven. So it all begins with the final goal in mind. It's a prosthetic modality with a surgical component. Because the surgery is not that difficult. Some of you that were in the clinic, you saw the surgeries. You know, after you get proper training, the surgery is not that difficult. You can place the implant in the bone. But where in the bone are you going to place the implant? That's the question, right? How far from the adjacent teeth are you going to place the implant? Is it in the best restorative position? That's what you have to look at. That's what you have to consider. So what is the final goal? It's a prosthetic modality with a surgical component. Because we can train and teach anyone to do the surgery. But it's the prosthesis that's the challenging part. Okay? You can't just drill, fill, and build. So treatment planning, there's a rule that we like to use. There's a rule of P. It says, pre-treatment planning prevents prosthetic problems. And that saying goes a long way. Meaning, because if you plan your cases ahead of time, if you plan it properly, it's going to give you less complications, less problems in the long run. And usually, a lot of the problems are prosthetically related. Right? What kind of problems have you encountered? What kind of prosthetic problems have you encountered? Right? One of the most common problems that we see is what? Screw loosening. That's a very common problem. And you have to think about, don't think about how to correct it. Think about why did that happen? How did that happen? And how do I prevent it from happening again? Because once you start with screw loosening, that leads to other problems. Because if it's not taken care of sooner than later, you may get screw fracture, screw breakage, right? You may get bone loss associated with implants, and ultimately you may get failure of the implants. Right? So there's complications, there's consequences related to some of these minor problems that could have been avoided. So pre-treatment planning prevents prosthetic problems. That goes a long, long way. And so we want to be minimal, we want to minimize some of those complications. Okay? Here's a case that I did. This was my very first anterior single implant case. This is probably the most difficult implant cases that you can do for any patient. Why? Because of the aesthetics. Because of the aesthetics. Okay? So patient looks like he had good tissue. The history of this case was the patient came in and said, Dr. Kim, can you place an implant? I said, I could place an implant, sure. He goes, well, I had a bone graft done already at another office. I moved here and I need an implant. I said, okay, I could place an implant. And so there's the implant.
Đây là kim len của tôi.
Right? This is an older. This is my first anterior implant case.
Đây thậm chí là
So
cái
I
ca lâm
placed
sàng
an
đầu tiên.
implant. So this is not even the tapered implants that we use today. All the implants today are tapered, right? Whichever system you're using. This is a parallel wall implant. Back in the old days, it was only parallel implants that was being used. So there's my implant placement. So this one, clinically, it's a success. It worked.
Về mặt lâm sàng
Right?
thì nó thành
It
công.
worked. Implant is in the patient's mouth. Patient's happy. Oh, happy. Dr. Kim, thank you so much. It looks good. It works. But look at this. What would you say? That's an aesthetic failure. An aesthetic failure is still considered a failure, right? But for him, he said it was fine because he just wanted to have a tooth in his mouth. He wasn't concerned about the aesthetics. He wasn't concerned about how it looked. So we can consider this a clinical success, but an aesthetic failure. So today in 2025, I know this is not going to be acceptable in probably 99% of my patients. 99% of your patients will probably not accept this, right? And so how do we avoid this? When I look at these cases, I try to take these cases and I try to say to myself, what can I learn from this case? This is my case, what can I do to improve it so this doesn't happen again? If you think about the history, when he said, I already had one bone graft already, I automatically thought because he had bone graft, that was enough. But looking back at the case, it probably wasn't enough. It probably wasn't enough. So here, I could have probably maybe do a little bit more bone graft, right? Or maybe do some more soft tissue surgery, right? So maybe I could have done that to improve the aesthetic result, right? So for this type of case, what would you change today? How would you improve it? Well, Mr. Jones, Mr. Lee, you're going to have a longer clinical crown. That's what we used to say. Well, I can improve it maybe by using maybe pink porcelain or pink shading, right, to mimic the soft tissue. Maybe it'll change and improve the aesthetics. But for him, he said, it's okay, I don't need it. You can't really tell. When he smiles, you don't see a lot of the gums, right, the gingiva. You don't see the soft tissue. And so for him, he was happy. But for me, when I look at this case, I consider this an aesthetic failure. Right? So we want to minimize those kind of complications. But that all depends on the patient. What's the patient's expectations? And so when patients come in, Dr. Town said we have to do a thorough medical history. Right? What types of medications are you taking? What kind of allergies do you have? Do you have hypertension? Are you diabetic? Right? So we need to do a thorough medical history. You want to do a psychosocial evaluation, meaning you want to evaluate the patient from just what kind of expectations do they have, right? So you want to do kind of a psychosocial evaluation. You want to look at the indications and contraindications for any proposed treatment plan. Radiographic evaluation. Long time ago, this presentation I used to say, including CTs if necessary. Today, 2025, it's absolutely necessary. We take CBCTs on all of our patients. And even here at Vietnam National University, when we're in the clinic, you guys are taking CBCTs on patients. We need that information. It's important. It gives us a lot of information so that we can plan our cases better. So CBCTs. We want to take study models so that we can evaluate the patients. Right? What's their occlusion like? What type of malocclusion do they have? And so today we're not doing models as much anymore because of technology. Right? We're doing intraoral scans. Now we can show the patients the models that we take on them. Right? We can determine different vertical dimensions, horizontal dimensions. We can even consider the biomechanics. Right? Do we want to utilize cantilevers? Can we utilize cantilevers? Treatment objectives, but ultimately the patient's expectations. In the previous case, single implant, patient's expectations were minimal. He just wanted a tooth. He didn't care about the aesthetics. So what was the patient's expectations? On a different patient, the patient, maybe on a young female, she's going to say it has to look perfect. Dr. Town's single implant case was beautiful. It matched perfectly with the adjacent central incisor. Right? So those are the types of patients that you have to be more particular with. But understanding what's their expectations. And you get that from taking all this information, and also the psychosocial evaluation. What are their expectations? So that you can come up with a proper diagnosis and treatment plan. And then, especially when we do any procedures, especially in the United States, we need consent forms. We need consent forms for both the surgery and the prosthetics. So we give our patients a consent form that has both components, because we're doing both the surgical and the prosthetics. So we do that in the United States. When we look at prosthetic considerations, you're going to see here many lectures throughout the 2 days. But when we place implants, we need to do extraoral evaluation, right? Look at the patient from the outside in. Don't just look at the teeth. Don't just look at the areas of missing teeth. But you want to look at the patient's facial structures, the outside extraoral features. You want to look at intraorally next. And so once we take all these information, we take models. Again, today we're not doing models. We're taking wax-ups, we're doing we're taking diagnostic wax-ups to make surgical guides, radiographic templates. But we can have, the more information we have, the better treatment planner you're going to become, and the more successful the cases are going to be. And so we want to do the evaluations. So again, today we're using scanners, right, to make models. We're taking intraoral scans, intraoral pictures, intraoral photographs to help us be able to plan our cases more efficiently. And then from there, we can even do our diagnostic wax-ups from the intraoral scans. We can make radiographic templates. We can make surgical guides, right, from all that information. So we want to take that information to help us become better treatment planners. Here's a case, single tooth, obviously unrestorable, right? What's going to be the best option? Is it going to be a 3-unit bridge or a single tooth implant? Which do you prefer? When you look at this type of case, what are you looking at? You have to look at everything, right? You look at the extraoral features, meaning, is it a male, female? Does the patient have large masseters? Do you think they're going to be heavy bruxers? Are they going to grind the teeth, right? Are the females going to grind their teeth? There are many females, many people in general that grind teeth, so you need to take that into consideration. So what's going to be the best option? Patient has a crown here, fairly stable, a tooth, a molar that has a very minimal restoration. Are you going to file down a fairly healthy, natural, almost virgin tooth, and then redo that crown to do a 3-unit bridge? Is that the best option? Or is it easier and better to do a single tooth implant? Probably a single tooth implant is going to be the best option. How about in this case, patient has a failing 3-unit bridge. These are cases that you see every day in your practice. What's going to be the best option? Posteriorly, there are no teeth, so you're limited in terms of the type of treatment that you can present to the patient, meaning you can't do another bridge because there are no teeth posterior to it. So then you're left with either a removable bridge or maybe some implants, right? So here, again, a similar case to what you saw earlier. Internal, external resorption. How are you going to treat this? Are you going to remove that tooth and then do a 3-unit bridge, right? Because that's a 2-unit bridge, but here's a natural tooth. Are you going to file down that tooth to do a 3-unit bridge? Is that the best option? These are choices and decisions you need to make. What's going to be your treatment of choice for this tooth? Fracture in the apical third. Again, probably a single tooth implant is going to be the best option. Okay. And so implant dentistry today is really now the treatment of choice. It's not the alternative. Long time ago, 15, 20 years, it used to be an alternative choice, right? Maybe implant dentistry is a better option, but today, it's really the treatment of choice. The standard of care, I think, in many offices today, especially in the United States. And I think all over the world, implant dentistry has really gone to another level in terms of being the best choice and best option for all patients. Baby boom generation, that's another generation of population in the United States where there's a lot of people that are missing teeth, right? And so it really allows us to take our practice to the next level. And so why are we doing implants again? Because we want to restore patients in terms of function. We want to give them the aesthetics, right? More and more people, it's all about the aesthetics. Speech, comfort, oral health, right? These are all reasons why we want to incorporate implant dentistry, because ultimately that's going to give the patients a much better quality of life. That's what we're looking for with our patients. They come in to seek dental treatment, but we want to improve their overall quality of life. That's what we're doing. And so it really takes a full team approach. Some of you that were in the clinics the past couple of days, you saw how many people are involved with implant surgery. It's a whole team. There are many, many different members involved with implant dentistry. You have the restorative dentist. You have the surgeon, right? Maybe you're doing both, or maybe you're just doing the restorative or just the surgery, but it all involves the restorative dentist. It involves the surgeon. It involves the laboratory technician, right? The laboratory technician is a big part of the entire team because they're the ones that's going to make the final restoration. And so we have to understand that it takes a whole team effort to make our cases successful. And even our dental hygienists, especially because after we complete our cases, the patients, they spend more time with the dental hygienist. They actually have a better rapport with the hygienist because they come in every 3 months, 4 months, or 6 months, and the dental hygienists are going to be the first ones that may notice a problem with our prosthesis, with the final crowns. Okay? But it takes a whole team approach. And so who do you have in your network? Because implant dentistry has to be multidisciplinary. Because it involves oral surgery, it involves periodontics, it involves prosthodontics, it involves orthodontics, because you need to understand, can you move teeth to create space to be able to place implants? So you want to incorporate all disciplines of dentistry. It really does take a team effort. And so we have to understand, in order to be successful, that triangle of success, it has to involve the surgical component, the restorative component, and especially the laboratory component. And all three components need to work in harmony to be able to give us the best functional, biological, aesthetic result. So all three parameters. Now when we look at final prosthesis, again, these are decisions that the restorative dentist has to make. Even though you may be the surgeon, you have to think prosthetically, right? Thinking, what type of restoration am I going to give this patient? What type of restoration does the restorative dentist want? So the restorative dentist, if you're not doing the surgery, you have to tell the surgeon what type of prosthesis you want. I want a cement retained prosthesis for the final result. Or I want a screw retained prosthesis for the final result. Right? What's your preference? What are you comfortable with? What do you think is going to be the best final prosthesis for that patient? Or maybe it's a combination. It's screw-mentable type. Are you familiar with a screw-mentable type restoration? That exists today too, where it's a screw cement retained restoration. So what's going to be the best option, the best choice for your patient? So the restorative doctor needs to understand the final goal. The surgical doctor, the surgeon that's going to place the implant, has to understand the final prosthetic result. Right? These are all choices that has to be made in the beginning. And it takes that team effort, the team to communicate that information so that you can come up with the best long-term result. Right? So this is your traditional cement type restoration, right? Cement retained, traditional crown and bridge case after the abutments are placed, right? These are types of restorations that we do each and every day. This is what we did routinely for our patients. I used to do 90% of my cases as cement retained. Today, 2025, it's shifted where I'm doing now, probably 80% of my cases are now screw retained, right? Because of issues with periimplantitis, because of retention, because of I want better retrievability. So I've shifted from doing almost all cement retained restorations to today, I'm doing now more screw retained. And these are the old generation screw retained type restorations, right? Where we have, right, metal baked underneath the porcelain, and we had the metal showing. So patients, after they finish with these screw type restorations, it's like, well, we have a better restoration for you, Miss Lee. What? It's screw retained, meaning it's retrievable. I can remove it without having any worry about cement. You know what the patient says? Well, why do I have silver fillings in my final crowns? Right? Because that's what we used to do in the past. Today, with better materials, better techniques, now we can avoid these types of issues as well. So, but today, the majority of anterior cases, posterior cases, what I'm trying to do is I want a screw retained crown.
Rồi những cái mô hình ở vùng
I think it's better long term because of not having to worry about peri-implantitis, because I can retrieve it better, easier, right? More easier to maintain, but it takes much more planning. Especially anterior implants. Takes a lot more planning. And when I talk about anterior implants, I'm going to discuss that later in the afternoon. It's so much more involved to plan your anterior implants. Takes a lot more planning for anterior implants. Right? Look at these. This is what I want to restore my final case with, screw retained restorations. I have retrievability, but in order to do screw retained, those implants need to be in a proper position. They need to be precise in where the implants are going to be placed to give you the result to be able to have a screw retained restoration without compromising the aesthetics. Right? Because many times if you have implants that are angled, what happens? It compromises the aesthetics. So that's where all the planning comes involved. That's where from day one, from the very first appointment, you have to understand what's the final goal, the final prosthesis. Right? Are you going to restore it as a hybrid? Or is it going to be some type of a all-on-X type of case? Right? What's going to be the best option, best choice for these patients? Those are the decisions you have to make from the very, very beginning. So how do you come up with a sequence of treatment? This next slide, you're going to see there's a lot of things you have to think about. This whole slide's going to become filled. Diagnosis, treatment plan. You have to do medical dental history. How are you going to plan your time? How are you going to plan your case? Productivity. Many different things. Cost of materials, right? What's going to give you the best predictability? In the United States, there's insurance involved, so how much does the insurance cover, right? What's going to be the best material of choice to use for your case, right? What about the occlusion? What type of occlusion are you going to give the patient, right? Those are things you have to think about from day one, right? You have to look about maintenance. When you finish your cases, how are you going to maintain long-term those cases, right? So these are all things that you have to think about from day one. Look at how many things we're thinking about. How many implants are you going to place? Are you going to place 4 implants? Or are you going to place 5 implants? Or are you going to place 6 implants? Or maybe you want to place 10 implants. Is that better? Right? There are reasons why you may choose one option versus the other. But look at all the things you have to think about. Right? Cement retain. Are you going to do this guided versus freehand? Right? There's a lot of information from day one. Before you do any surgery, before you pick up the scalpel, these are things that you have to think about for all of your cases. Lab fees. Which labs are you going to use? Am I going to look for an in-house lab? Am I going to refer it out to another lab? Right? So look at this. A lot of information. So what's part of record taking? We take our radiographs. We do our periodontal charting. Right? We do hard tissue charting. We do soft tissue charting. We take photos. Right? You want to take all your photos because look at her smile. Right? Look at her smile. Right? Take videos. You want to see how she speaks, when she smiles, when she speaks, when she's in repose. This is all information that you can gather with what? Use your iPhone. Very simple. Very simple. That gives you a lot of information. So videos, photographs. We take videos on every patient. And now we can scan. So we can take all the digital information. Get as much information as you can. So scan every case. From day one, first appointment, that's what we're doing. X-rays, hard tissue charting, soft tissue charting. We do photos, videos, intraoral scan, so that we can plan our cases much more efficiently. That's what we're looking for. Because that's going to make you a better treatment planner. That's going to make you more successful with your implants. And so we'll go through this one case. What time? How much time do I have? I'm sorry. Okay. 15 minutes. Okay. So let's look at this case. This was the case I showed you earlier, right? Anterior implant. I'm sorry, anterior tooth that's failing. What's going to be the best option for this patient? 64-year-old male. He was told he needed to remove his tooth. He was asymptomatic and he came in for a second opinion. And I told him, yes, you have resorption. It's not going to last. It's failing. If you leave it alone, you're going to lose bone and so forth. It's going to compromise more, right? Maybe your teeth. No medical history. He denies any medications. History, past history was he had a 2-unit bridge from his 2 central incisors. So if we do the universals, what is it, 11 and 21, right? Those 2 teeth. Periodontal status stage 1 grade A, according to the new period classification. Radiographic findings, he has endodontically treated number 8 with some internal resorption. He had mild probing depths with localized gingival inflammation. Internal resorption, unrestorable. So our plan was to section it and place a single tooth implant with immediate provisionalization. Now when you do those types of cases, those are the most challenging cases that you can attempt. Anterior, single tooth, right, in the aesthetic zone, so it takes a lot of planning. So we go ahead and we perform atraumatic extraction, doing this as a flapless approach. Right? We saw that earlier as well, so we can look at palatal view. After sectioning the tooth, because it was a 2-unit, splinted, so we section it in the midline, remove the central incisor atraumatically, we debride the socket, we go ahead, we're going to place our implant. This was the implant I showed you earlier, right? If you critique it, it's probably too buccal, too facial, right? Not ideal, because I can only restore this as a cement retained crown now. If I wanted to do this as a screw retained, I probably cannot do this as a screw retained. Although today, with better technology, we have what's called the angulated screw channel. We can probably convert this to a screw retained in spite of it being more buccally positioned. Now the reason this implant is placed like this was because I tried to engage the palatal bone, right, to get primary stability. Because we were always taught when immediate implant dentistry was the hot topic back in the early 2000s, late 90s. Number one criteria for immediate implant placement is what? Primary stability. And the only way to get that primary stability is if you engage that palatal bone. And so that's what I did. I wanted to engage as much palatal bone as possible to give me the best primary stability. And so that means I had to angle my implant to the buccal, to the facial, to get the best primary stability. Today, 2025, with better planning, we can avoid this type of result by having it in a more ideal position where the screw channel is going to come out to cingulum. So we can do that today. So here, this was a large diameter implant, which I don't do today anymore, I will tell you. The largest diameter implant I place is going to be a 4.0, 4.1 diameter implant for several reasons, and we'll go through that in the presentation this afternoon. But this implant was a 4.7 by 10 millimeter length implant, and then we're going to use this fixture mount. That purple fixture mount, we can use that as a temporary. So we can prepare that and use it as a provisional. So with the Zim V, this is the previous generation, the Zimmer, right? This is the TSX implant. It comes with a fixture mount that we can use as a provisional abutment. You can prepare it and use it as a temporary abutment. So that's what we did there on the photograph on the right. And then we can go ahead and fabricate a provisional over the provisional abutment. This is to be able to provisionalize on the day of surgery. So here's our provisional. Here's our abutment seated, sealed, and this, at the time of this procedure, was a cement retained crown. And here's our cement retained provisional. Okay? When we did this, when you do this, if you're going to make a cement retained provisional, you want to make sure you cement it with a permanent, strong cement. You don't want to use a temporary cement if you're going to fabricate a provisional that's cement retained. Right? So if you look at the literature, the Tornell studies, he says it has to be fixed with a permanent cement so that you can minimize any micro movement of that provisional. So cement retained provisional, keeping it out of occlusion. So here's our post-op clinical radiograph, photograph. And the reason for provisionalization is to help shape and sculpt soft tissue. That's what you want to use a provisional for. So you want to use your provisional to give you the idea of how it's going to shape and sculpt the final restoration. That's the whole idea behind provisionalization. Right? And so for this case, we used that fixture mount to prepare it as a temporary abutment. This was an older case, so we went ahead and we did it with impression material, using a polyether material, Impergum, and then we fabricated a custom UCLA abutment, and then a final single cement retained restoration. So this is now going on about 18 years post-op, but you can see when we redid this crown, we redid the crown and the central incisor number 9 together to get the color match and the porcelain to match better. But over time, what do you see in this case? Number 9 started to super erupt a little bit. That's why you're seeing that gingival margin, right? That exposure to the gingival margin, because the tooth actually super erupted over time. He knows that he's going to eventually lose that tooth, but he was waiting, right? He just wants to wait a little bit more before committing to doing an implant in number 9. And so when he comes back for implant in number 9, what am I going to do differently today? I'm going to do things very differently than when I treated number 8. Right? I'm going to plan this now much better because I want to have a screw-tained final restoration. I want to have a screw-tained provisional on the day of surgery to help give me better soft tissue, to help give me better emergence, to give me an idea of what the final restoration is going to look like. So we're going to plan this much more differently today than what we do in the past. We're going to take CBCT to evaluate the bone. We're not going to place a 4.7 diameter implant like I placed in number 8. Today I use a smaller diameter, meaning a 4.0, 4.1 diameter implant. That's the largest diameter implant that I'm going to place. And we're going to do a lot more bone grafting. So that's what I do differently today. But this is the case today, right? That implant is still stable almost 20 years later. 20 years later, that implant is still very stable. Soft tissue is very stable. Look at the soft tissue, right? And I'm not just saying that because I'm a periodontist now, right? As an implant surgeon, implantologist, you have to look at the soft tissue, right? But look at the results. That's what you want to see. Not 1 year later, not 5 years later. You want to see that 15, 20 years later. That's what you want to see. Look at the bone. And we know the soft tissue is stable because of the bone, right? Because of the interproximal bone. That's what you have to look at, right? So a lot of factors that go into understanding how do you make your cases successful, right? Look at the CBCT today, right? Doesn't look like there's much bone on the buccal plate. We'll talk about that later when we get into immediate implants. But there's a reason, there's something going on, but it's still stable. It's still stable in the patient's mouth. Okay? Final results. So let's go through this one last case. Multiple extractions with immediate placement and provisionalization. Similarly, right? This is a patient that presented with a failing maxillary anterior bridge. Again, clinical photograph, clinical radiograph, 74-year-old female. Her anterior bridge fell off. And she came in, can you re-cement it? Or, am I going to lose those teeth? Medical history, no medical history, no medications. Patients had a history of previous implants in other areas of her mouth with implants. Periodontal status, generalized stage 2, grade B. I'm sorry, stage 4. Stage 4. That's a typo. Radiographically, endodontically treated teeth, short clinical roots, recurring decay, and unrestorable failing maxillary anterior bridge. The plan was to remove those teeth, and then we're going to go ahead and do some immediate implant placements, but we're going to use a surgical guide, as you saw with Dr. Town's presentation. Surgical guide with also immediate provisionalization. So we're doing a little bit more involved, a little bit more advanced type of a case, but we want to do the planning. So we're going to do the planning. Here's the radiographs, failing anterior teeth. You can see why they failed, unrestorable. Here's the frontal view. You can see her previous implants are not healthy as well. She knows that, but she's a missionary in South Africa, and so that's why she only wanted to address her immediate concerns, the anterior segment. There's her occlusal view of the existing prosthesis, and you can see the severe wear. When you see these types of patients, these types of cases, you have to really think and remember, why did this happen? How did this happen? Does this patient have any type of parafunctional habit? And what's going on? Why do we have so much wear? So you have to have all that information in the back of your mind. And then similarly to you saw this morning, I also use implant concierge. So we're going to plan the case. Now we have to plan this way because patient had previous implants, right, from another office. And so because of how those implants were placed, if we didn't do this guided, it's going to be very challenging to place these new implants in an ideal position.
rất là khó
We don't want to invade those implants in terms of when we place our new implants. So we had to do this guided. So here's our extractions. We're doing this, again, atraumatic extraction. We have a surgical guide to help us place our implants in an ideal, precise, predictable manner. Implant fixtures placed. We're not going to go through a video for the sake of time, right? But atraumatic extraction. And then we're going to set up for provisional. For this patient, we used these multi-unit abutments to help us with the provisional. Temporary cylinders in place. You can see the angulation of those implants, right? Because of our bone, because of the existing implants, we had to angulate those implants. And then using these temporary cylinders, look at the angulation of this implant, right? But we can use angled cylinders, angled abutments. We can use all that to be able to help us provisionalize, even in spite of the angulation with a screw retained provisional. And then for us, we use a lot of baby graft, which is your sticky bone. We use a lot of PRF. There's your screw retained provisional after surgery. Okay? And we let that heal. Access hole, screw retained. In spite of the angulation of the implants, we can still convert it to a screw retained. So, but look at the implant position and placement. If I didn't angulate that implant and I placed it where it should have been, it would have invaded that existing implant. So there's no way I can avoid that unless I plan this with a guide and make it more predictable, more accurate. So we place our implants, we do grafting, temporary cylinders, we let that heal, and then we can take it to final restoration. This is the prosthetic video of converting to the provisional. We're going to go through. Here's the final prosthesis. Again, this is a screw-mentable prosthesis that we made. We wanted to have the retrievability, right? But we did a screw retain, so we did it in the patient's mouth. It's a 5-unit zirconia screw-mentable bridge. There's the before and there's the after. Look at the parallelism that you see from the panorama. They weren't parallel clinically, right? It looks parallel, but we planned it so that we can avoid those implants because of the angulation of the previous implants. But we're able to plan this in a way that we can finalize this as a screw-retained, screw-mentable type of restoration prosthesis. There's the before, there's the after. Look at the implants, right? Nicely placed and positioned before and after, and then she's going back. And when she comes back to the United States, I actually did complete her upper right side, removing those failed implants and so forth. So we want to be able to embrace technology, right? Trying to make one difference at a time, make a difference one smile at a time. Since we managed to get it in, we managed to do some bone graft, we'll take the x-ray, we'll play again, hope for the best. We renovated our office, so we have a new one, but we're always looking to the future, embracing technology, right, techniques and stuff. For me, that's my daughter. She's a second year, she just finished the second year dental school. She just started third year dental school, like maybe some of you are. That's my wife, Jamie, who's here with me in Vietnam. Right? But I also have another daughter, younger daughter, Sarah, here in between my wife and I. But we're always looking to share what we do, and if you ever want to share information, just always reach out. And I have a few more presentations today. Thank you for your attention. Glad to be here.
Thank you, Dr. Josh and team for presentation, long presentation and interesting presentation. And now we have a 15 minutes for break time. Thank you, and please come back after that to